We're live.
Hey everybody. You guys come on into session. We are about to get started and do our full 1 hour session on tuberculosis today. So while everybody's kind of coming in and getting caught up, I want you guys to come in, tell me where you're from, what nursing school you're from, and then we're just going to chat for a few minutes. I've got Casey in here with me today again.
Yeah.
Okay. And today is just our plan of care and our patho, diagnosis, signs and symptoms, all of that for tuberculosis. You guys will be well prepared going into next semester. I know most of you guys are on break right now, so I am thinking it's pretty cool if you're coming in and studying even on break. We have a couple of opportunities for you guys coming up for fall. So we are off for the next week or so, and we've been planning for you guys for fall. So a couple of opportunities that we have created for you based on your feedback and telling us what it is that you need in order to learn all the things in nursing school and have us teach you all of the things so you can master everything. So the first thing that we're going to be doing is our Facebook Live seminars. We started doing those just as kind of testers and feelers at the end of last semester. And so what the Facebook Live seminars those are seminars that we do just on Facebook Live. There's nobody in here in person. Most of them are 1 hour. There are a couple of them that are 2 hours that are a little bit more intensive, but most of them are 1. And we have the full schedule already set up on our booking site. So you can either go to our website at www.ivyleaguetutoring.org, or you can go to our booking site, which there are tons of links all over our Facebook to the booking site as well. And those are ready and up for next semester. So what I'm doing is I'm covering different body systems every week. So it doesn't matter if you're in first semester, second semester, fourth semester, studying for NCLEX, it's going to help. I'm doing the renal system 1 week, I'm doing GI system 1 week, we're doing cardiovascular. So it's teaching you those overall basic concepts that you need in order to be successful in that body system. So those are ready and up for schedule. They're only $25. Once you register, we put you into our private event page. We will live stream the video on the date and time it says when you guys are registering. But if you can't make it at that time, that's absolutely okay. We're going to post the recorded video into that Facebook Live event page that you're a part of. And it will be there for 14 days is how long we keep it up. After we have done the live stream, put the recorded video on it, we're also going to send practice questions that go up on the Facebook page too. We do mnemonics to help you remember the information, and then we do giveaways based on whatever you guys give us feedback on. So we may do some worksheets on ABGs, and whoever finishes those worksheets and gets the answers right, we're going to do a free giveaway for some of our boutique items. And so it's really fun. The Facebook Live stuff is fun and it's exciting, and it really presents you nursing school in a different way so that you're not memorizing and you're really understanding the content. And so that is why we are bringing you the Facebook Live. That way a lot of people can join in, a lot of people can watch, you can have it recorded later and rewatch it as many times as you need to in order to master the body system. So you'll see on our schedule that every week we're going to have a different Facebook Live seminar. We'll have a body system 1 week, and then the next week we'll choose one big giant disease process from that body system. So let's say our first one I think is renal. So we're going to go over a whole full renal review with a plan of care. And then the next week we're going to do AKI, which is acute kidney injury, versus CKD, which is chronic kidney disease. And so that's going to help you to synthesize and to understand how the renal system plays into specific disease processes. We set that up for the entire semester. So we'll go and do cardiovascular review, and then the next week we do CHF. So you're able to really synthesize the information and to understand and to learn all of the things. So those are up and ready to book for fall, and they're going to be every single week, once a week, from August, the end of August, until we break for December. We're also going to be doing a couple of free ones, and those are going to be once a month. We're going to be doing some infection control and precautions, and I'm going to do an insulin chart because everybody seems to struggle with that. So if you guys have some issues in nursing school, you're like, man, I have learned this 1,000 times and I still can't remember it, that's something we want you guys to send us so that we can prepare some curriculum for you, and we can get those seminars up and running. Okay. So Facebook Live seminars are up on the booking site. We're going to have the free ones that should be up. We're going to be posting some events for those, so be looking for those here pretty soon. If you haven't joined our VIP page, that would be a good opportunity for you as well. We do giveaways and promos, and we do practice questions, daily practice questions that have giveaways every week too. So if you answer the daily practice questions, you will get entered into a drawing every week to get a Starbucks gift card. So we're making sure that we're keeping you caffeinated and smart at the same time, okay? So the VIP page is a good place to start. There's a link on our Facebook page, so if you guys want to join that, I would hook up with that too. The third opportunity we would request for you to do is to join our text alerts, because we'll be sending out when we're going live. We'll be sending out promo codes. We send out half-off codes to make sure that we keep our sessions affordable for you. And so if you want to join our text alerts, you're going to text the word nursing, N-U-R-S-I-N-G, to 85100. Text nursing to 85100, and that will get you our text alerts, and we send out announcements and fun things and promo codes and things that are unique just to the text alerts. Okay, so for the fall, we have a lot of exciting things for you guys. So in addition to the Facebook Live seminars and the free seminars that we're going to be doing once a month, we are also going to be offering Facebook Live seminars for almost every subject that you have in nursing school. So we will be doing sessions for PD, OB, evidence-based practice or research. We'll be doing pharmacology. We're doing a brand new program for pharmacology. There's going to be a lot of raps in that one. So we're trying to find like really interesting and creative ways to bring pharmacology to you. So we're going to be doing some raps. Casey's coming in and she's going to be part of the rapping. So excited for that, because we're going to be good at that. We also do, what am I missing? Pathophysiology. Any med-surg adult courses we're doing as well. Let me see if I missed anything. Oh, and we're going to be doing full ATI and HESI reviews. So if you are a student that's in your later semester or your last semester and your school does either the ATI or the HESI comp, we prep you for that too. So it's usually after the first 6 to 8 weeks of school start. So usually we start the comp preps in October. And those are going to be once a week. They're Facebook Live and in person. Those are 2-hour sessions. They're very intensive. And every single one is going to cover a different aspect of the ATI and the HESI. So 1 week we'll do mental health. 1 week we do OB. 1 week we do peds. 1 week we do fundamentals. So be looking for those two, because those are an excellent review to get you ready for comp so that you can graduate. And then we'll start you on NCLEX prep. If you're a student that's coming in that hasn't done NCLEX prep, or that has taken the NCLEX multiple times and hasn't been successful, the ATI and HESI reviews are a great content review for you too. So that's something anybody can join in on. You don't just have to be studying for ATI or HESI. We had some students that came in that are just third semesters or maybe second semesters that just want an overall view on these nursing concepts. So anybody can join in on those and register. We don't have those up on the booking site yet. We will have those up by September 1st. That's our goal, to have all of our seminars up by September 1st. So pretty much any class that you're in a nursing school, we're going to have sessions available for you, whether you're here in person or whether you're online and joining in with us. Okay. So with all that said, and you guys know what's coming for fall.
Yolanda said that she's having trouble in calculations.
Okay.
Is that an easier way to understand?
Yes. So we are going to do a math calc. We will do a seminar for that. I'm glad that you said that, because I do need to add that. We did just add a nursing charting mastery class.
Yeah.
That's a really big one. We've had a lot of students say they do not get that taught in nursing school. It's never taught. They don't know what to chart. I was a legal nurse consultant for a couple of years, and so that is one of my specialties, and one of my passions is to make sure that we are protecting the nurses and that they learn how to chart appropriately so that you can avoid lawsuits later on, and that you are making sure that you're charting beautifully so that you're meeting the requirements of your nursing license too. So we are doing a nursing charting seminar. That one's already up and ready for booking and available. We are also going to do, there was another one that somebody had asked. We're going to do an Ekg Master Class. That's another one. And that one already is up and ready to also to schedule. I think that one's coming in September. So we have Ekg Mastery, we've got nursing charting, and we have pretty much anything that you can need in order to be successful. So take a look and see what we've got. When you go onto our booking site, you're going to choose the Facebook Live Learn All the Things seminars, and you can see our schedule for those. And then we'll be adding some as we go for the fall, and as we get more feedback from you guys and you let us know what you want to see, we'll add some more sessions too. All the rest of our sessions for all of the courses in nursing school will be up by September 1st, so just be ready for those, and keep in mind that we will have those going all semester long, and then we'll get you prepped for ATI and HESI, and then by December we're ready to do another NCLEX prep class. So we have lots of things going on, and it's super exciting. So for today, we are going to be doing tuberculosis. All right.
Yeah.
So as you guys come in, I want you to tell me where you're coming from, what nursing school that you're at, and then tell me anything that you know about tuberculosis. Give me some fun facts that you've learned from your nursing school classes or your textbooks, and let me know what you know about tuberculosis. And then we're going to go ahead and get started. Okay. And if you guys cannot join us live right now, that's okay. This will be recorded and on our Facebook page, probably for the end of time. Okay. And we have all of the other ones that we've done for free are located on our YouTube page, so be sure to find us on YouTube, and there's a whole bunch of really cool free videos on there too for you guys to take a look at. All right, so are we ready to learn all the things?
Yeah, we are.
Learn all the things. All right.
Shall we?
Let's do. Okay. I'm gonna get my markers. I love markers so much.
The tuberculosis.
The tuberculosis. All right, so you guys come on in, and I want you to tell me what you know about tuberculosis. Give me some fun facts. Tell me what you know. And then we're going to create this beautiful board of a whole plan of care for tuberculosis patients. So
Jenny says it's contagious.
It is contagious. That is most definitely true. You got it. What else?
N95 if you want to survive.
And who said that?
Me.
You did. Casey said N95 if you want to survive. So there you go. We know that's coming. All right, you guys, you can still be coming in. Remember, there's a 10.
Noelle said you need airborne precautions.
Yes, we definitely need airborne precautions. You got it. So you guys can keep coming in and giving me some fun facts, and we'll kind of shout you out as we're going along. All right. So I want you guys to tell me what you know about tuberculosis. So tuberculosis.
Camille said can be pulmonary and systemic.
Can be pulmonary or systemic. That is absolutely correct. So tuberculosis is a virus or bacteria. What do we know?
Anna says bacterial disease.
All right, so this is a bacterial disease. Does anybody know the actual name of the bacteria that causes tuberculosis?
Bet you $5 I couldn't spell it.
Well, I'm going to try. It might be a little rough, but we're going to make it. I know there's a little bit of a lag, surely. All the people are typing or Googling.
Look, the thing is, it's a lot of characters.
It is. It's a lot. It's a lot. All right. So what we do know is tuberculosis is a bacterial disease. That means it is able to spread from person to person, and it is very freely spread from person to person by airborne. That's what you guys have told me so far. Still nobody knows the name? No? I mean, I know the lag time's up too. All right. So tuberculosis is Mycobacterium.
Oh, Kaylin came in clutch right when you were writing that.
Oh, what'd you say?
She knew.
Mycobacterium tuberculi.
She nailed it.
All right, very nice work. Kaylin.
Kaylin Martin.
Oh, I know her.
And Ana Hernandez came in too.
Oh, get it, guys. All right. So we got tuberculosis. We know it's a bacterial disease. It is caused by a bacteria called Mycobacterium tuberculi. All right. So what do we know? How does this happen? How does it get transmitted from person to person? We don't have a lot of tuberculosis here, all right, but in other developing countries, there is a lot of tuberculosis, and it does go airborne. So let's set up a situation. Let's say we're on a plane, and we're traveling internationally because we're famous and great. And so we're doing, our traveling celebrity thing, and we're in the plane, and somebody has tuberculosis, whether they know that they have it or they don't. Chances are they probably don't. Because at the beginning, tuberculosis doesn't have a whole lot of symptoms, or if it does, they're very, very vague or constitutional symptoms, which we're going to talk about in a few minutes. So this person is sitting a couple of rows in front of you, and they're coughing. And picture this, if you will, that this Mycobacterium tuberculi is floating up in the air, back, a couple rows back to you,
and then you
yawn in all your glory, and then you're a little tired, right? Or you're taking a selfie, and you're, and then you breathe in that bacteria. Casey just spit out her food. Y'all can't see her, but it really did just happen. It was very embarrassing for her.
It really was, though, but that goldfish flew.
So, now you have breathed in this tuberculosis. So I want you guys to tell me, once you breathe in this tuberculosis, or Mycobacterium tuberculi, there are some different places that it can go in your body. Tell me what different places it can go, what the name of it is called when it goes to those different places. Ready, go. Oh, here we go. Here we go. Well, come on. Come on. Here we go. Here we go. Okay. You're dancing, but they don't know that, so it just looks like I'm trying to sing something that's not.
Oh, this is awkward.
Well.
It's more awkward for you than for me.
Sure does.
Camille said lungs.
All right, that is absolutely true. So this could go into the lungs. So I breathe it in and it goes straight into my lungs, right? That is pulmonary TB, right?
Kelly says bronchioles.
Yep, you got it. So if it's going to go pulmonary, okay, now it can just sit there for a minute, right, or years, okay? So it can go somewhere inside of your body, whether it be lungs or somewhere else, but usually if it's going to go and deposit itself into your lungs, okay, then that is something that is, it's usually probably going to become an active infection. So once it goes into your pulmonary system, it's going to be pulmonary TB, right? And that usually is going to end up becoming an active infection, meaning you're actually going to have the active infection that we need to treat. What other places can it go, and what's that going to look like?
Camille says lymph nodes.
Okay, yes, it can go into the lymph nodes or any kind of organ system. Does anybody know what it's called when tuberculosis goes and deposits itself into the organs? Hint, it starts with an N. All right, I'm just going to write M because it's going to take just a second. And then while you guys are kind of answering that, I want you to tell me if there's any other places that it can go or what it looks like whenever it gets into your body.
Shireen said brain.
Yep, it's going to go into the organs, and it is called, does anybody know? Not yet? Okay. Like we talked about over here, when it goes pulmonary, it goes active. It can also go just into your blood, right? Or it can go into anywhere in your body and form a latent infection. Does anybody know what a latent infection means?
Metastasis. Kelly.
It doesn't usually spread as far as cancerous, but it can go across your body but still remain a latent infection. So a latent infection means that you have been exposed to the bacteria. The bacteria is in your body. However, it's not forming an active infection. So this one is just kind of like lying in wait, okay? So it's just kind of hanging out. It's in there in your body. You've definitely been exposed and you have the bacteria, but it has not become an active infection, okay? These patients may or not test positive for TB. Usually they will, but we won't see anything on their chest x-ray because it's just the bacteria is just kind of lying around and waiting to strike. It's kind of creepy, actually. All right, so that's a latent infection. It can go anywhere and just sit and kind of lie in wait, okay? Then if we look over here and it goes into any of our organs, that is called miliary TB, all right? So miliary TB is when it goes and deposits itself into your organs. And that is very, very difficult to diagnose and to treat because it's not very common for us to get tuberculosis of the organs, but it can end up causing MODS, which is multiple organ dysfunction syndrome, and the patient can die very quickly from getting this bacteria that has now invaded our organs, all right? So if we go and we get this, and this is the first time, right? So I have been in an airplane, and I breathed in this Mycobacterium tuberculi, and it went pulmonary, went into my lungs. It's forming an active infection. If it's the first time I've ever been exposed to that bacteria, the first time I've ever had it, that is called my primary, all right? That's my primary infection. So this would be my pulmonary, it's active, and it's also my primary. That means it's my first infection, okay? So you may see any of those on your nursing exam, and that's what each of them means. Pulmonary means it went into my lungs. Active means I actually had the bacteria crawling around and multiplying in my lungs. And primary means it's the first time that I got the infection, and it's a primary infection. It's the first time it's ever happened. Because what can happen is we can successfully treat tuberculosis, but it could still have some bacteria that's still lying in your body and becoming latent, meaning it could activate at any time. All right? I know that seems, it's not confusing, but it is a lot to remember. So if there's any questions on what I just went over, I want you guys to let me know. We'll come back and go over it again. So these are the different places that you can see it. So let's just say that we have a pulmonary infection, all right? So I've been in this plane and I breathed in this bacteria. It went into my lungs. Now, what happens once a bacteria goes into your lungs? Now, pneumonia looks a certain way and TB looks a very different way. So I want you guys to tell me what happens to TB when it gets into your lungs and what it does to your lungs that's different than what pneumonia does. I'm going to attempt to draw some lungs.
Oh, Lord.
If y'all have seen my videos before, you know that the dear Lord did not bless me with artistic ability. So I'm going to do my best, okay, but just bear with me. So I want you guys to explain. You have an assignment, so go ahead and give me.
Christina said lungs will pocket it. Amber says cause scar tissue.
All right, it is going to cause scar tissue.
Whoa, those are some blocky lungs.
Hold on. Give me some time. I'll have to delete a couple of things in order to get it right. Hold on.
Rounded corners, rounded corners.
Well, I tried. Okay, here.
That's better.
Is it better? Okay.
Still looks like a box.
Yeah. If y'all could pray for me, that would really be helpful.
Like, okay, so we got 2 tombstone lungs.
Yeah, that's what I'm going to do right now.
Because you're going to die.
Yep, sorry about that. All right. So whenever pneumonia comes in,
Noah says it embeds itself in the lung tissue.
Yes, that's exactly what it does. Who said that?
Noel.
Noel.
The burrowing bacteria. Odom.
Oh, our friend Noel.
Our little sweet little pumpkin
yeah,
friend.
Good job, Noel. You've been well taught, so I expect a lot out of you today. All right, so what we know happens is once it gets into the lungs, pneumonia is going to kind of spread generally. I'm not going to draw lungs again very well, but I'm going to do a very, very just like this. I know because I'm terrible and I get it. Pneumonia, when it comes in, it's going to start like with maybe a little bit of kind of fluid at the bottom, and pneumonia typically is going to spread like this. We'll see these like patchy infiltrates on the x-ray. So your
started from the bottom, going to the top.
Usually it starts at the bottom. Sometimes you can have an upper lobe, sometimes you can have middle lobe, not as often because your alveoli and fluid tend to gravitate toward the bottom, right?
Yep.
So when you see a chest x-ray of a patient with pneumonia, usually pneumonia is going to spread outwards and you're going to see some irregular ends because the bacteria is kind of growing, right? And so eventually that's kind of what it's going to look like. Now TB is very different. TB has a job to do and it knows what it's doing, okay? So TB comes in here, and instead of going down to the bases of the lungs and kind of having these patchy infiltrates, it forms, usually in the upper lobes, something very, very specific. Does anybody know what the name of it is called when it burrows itself into the lung tissue? It's this little spot right here. So pneumonia would look something like this. TB is going to look like this. All right, so that would be TB. This would be pneumonia. It looks like a dove flying.
Yeah, I was about to say it's a little peaceful dove.
Well, I am.
Camille said cavern?
A what?
Cavern?
No, this one starts with a G.
I read it in a question form.
Oh. Okay.
Cavern?
Anybody know? Noelle should know this.
Come on, Noelle. She said, hi, boo.
Anybody?
I feel like they got it. I feel like
I feel like we're on the struggle bus today.
Girl, we're on breaks. Nodules?
Yeah, no. Start the G. Anybody? This is called, let me do a different color. This, whenever it burrows itself up into the top, typically, of the lungs, it is called a gone focus. Everybody should be going, ugh, right now because you should have known that.
I mean.
Okay? No? Yeah, we should know this. All right. If you're an Ivy League student, you know the gone focus because I say it all the time because it's so weird.
Noelle said emoji. I distracted him out.
Gone focus, G-H-O-N, the gone focus. Now what happens differently here is pneumonia will kind of spread patchy-wise, right? It'll spread lengthwise usually. The gone focus is where TB walls itself off in almost a perfect circle, all right? And so it takes the bacteria of TB and it's going to form a wall around it like this. It is almost like if you look at a TB x-ray, if you're in front of your computer right now, if you're watching from the computer, go on Google really quick and I want you to Google TB x-ray and you'll see it is at the top, all right? Once you see the x-ray, look at the top and there's almost a perfect circle on the x-ray because that's what TB does. It walls itself off and it forms this gone focus. And so instead of spreading this way like pneumonia does, it spreads forward into the lung tissue. So what happens is it starts to eat through the lung tissue. It forms a caseous appearance, that's probably what she was saying earlier, or a cheesy, cheese-like appearance, which that sounds so disgusting. But that's what you'll see on exams. This is a cheesy appearance or a caseous appearance.
Like a Swissy? Or
yes, like
cheesy?
Swiss cheese.
Okay.
Because it's trying to eat its way through the lung tissue. So what can happen in some of our tuberculosis patients and why at the end of tuberculosis, they start having hemoptysis. They're going to start coughing up blood because that means that the bacteria is eating its way through your lung tissue and about to form a big giant hole in your lung.
Uh-oh.
It's a big deal. So that's why, and this is red flag, on your nursing exams, do not choose hemoptysis as an early sign and symptom of TB because we will not see that until late signs when the gone focus and that bacteria has eaten almost all the way through the lung tissue. All right? So this is how TB works. It's going to come in here, it's going to wall itself off, it forms a gone focus, and it starts to eat its way into the lung tissue. All right? So now I'm forming this on my lungs. I may not even really know that yet. I know that I'm not feeling quite right, okay? You know that feeling when you know you're kind of getting sick, but you're not really sick yet? You're like, I just don't feel good. That's what we usually see at the beginning of tuberculosis.
Like so general malaise?
General malaise. If you ever have to guess what's a sign and symptom of, doesn't matter.
Early symptom, malaise.
Malaise means I feel like garbage, okay? And pretty much everybody does. So I want you guys to tell me what the early signs and symptoms of TB are. They're called B symptoms or constitutional symptoms, and I want you to tell me what those look like. Since we didn't get gone focus or miliary, I'm expecting a lot out of you guys right now.
Hey.
Even though they're on break.
It's coming. It's coming.
Okay.
It's hard to recover from break.
It is hard, and your brain kind of goes away on break for a little while.
Deborah says night sweats. Or Debbie. I think it's how she likes to go by.
Debbie?
Debbie.
Our friend Debbie?
Our friend Debbie.
Hey, our friend Debbie.
Camille
All right, so
fever.
early signs and symptoms. Let's start there.
Intermittent fever and flu-like symptoms.
All right. These
Cough.
early symptoms are also called B symptoms or constitutional symptoms. You are always going to, not always, you're mostly going to see those with a couple of disease processes. So I want you guys to know these symptoms because you're going to see it in other diseases other than TB. So in TB, leukemia, lymphoma, and HIV, these are the early B symptoms or constitutional symptoms that you're going to see.
Weight loss, fatigue.
We got it.
Fever, cough.
Weight loss, fatigue. Something happens at night. What
Night
happens
sweats.
At night? Night sweats. And this weight loss is sudden weight loss. Like you weren't expecting to lose weight and you just all of a sudden dropped 10 pounds in a month.
Remember last month when I thought I had TB?
Yeah, she dropped like 10 pounds in a month. It was bad.
Don't worry, guys. I'm clear.
Huh?
I'm clean. I said, don't worry. I don't have the TB.
She's had the PPD. We good. All right. So it's weight loss, night sweats, fatigue, fevers of unknown origin. So these are things that are just occurring kind of out of nowhere. All right. So sudden weight loss without being intentional. Debilitating fatigue. They're really tired. We've got night sweats. We have recurrent fevers with either no other symptoms or just very, very vague symptoms like malaise. Malaise, our friend. Okay. So those are going to be the early signs and symptoms. So if you come into a doctor's office and just say like, hey, I just really haven't been feeling well and I've been, losing some weight, and I mean, that could be 100 million different things, from cancer to mono to you're coming off the flu. And so there's a lot of times we will not catch TB at this point because the symptoms are pretty vague. Now, we would have to ask as healthcare providers about the night sweats because there are very few things that actually cause night sweats. Some patients just think they're breaking a fever, or they think it's really no big deal, I was just hot. So it's usually something you have to ask. If I hear somebody saying sudden weight loss, they're feeling tired, they just had kind of fever here and there, that's a big thing I'm going to want to ask. Have you had night sweats? Night sweats are never normal, okay? And so if I hear this would red flag me to TB, but I would have to see all of these things at one time. If a patient just come in and said, hey, I'm not feeling well, TB probably wouldn't be the very first thing on my mind, especially here where we don't have quite as many cases, all right? So these are B symptoms or constitutional symptoms. These are what we're going to see first, all right? And then after these symptoms appear, what start coming next? Nursing schools love to test on what kind of cough that TB has, early, middle, late. So we're going to talk about what the progression of the cough looks like.
Hint, hint, it changes.
Yeah. Dum, dum, dum. So usually early on, we're going to have a dry cough. Now, why would it be dry at first?
Debbie says, in general, nothing is normal at night. You're supposed to be asleep.
Well, there you go. So she's right,
Words
though.
to live by.
It's true because, I have to prop myself up on a bunch of pillows because I can't breathe at night. Not normal.
Not normal.
Not normal. My throat's burning at nighttime and I feel like I'm going to puke. You got reflux. Not normal. She's right. You should be sleeping at nighttime. That's right.
Usually I wake up, I'm like, man, I'm hungry. Hypoglycemia. Not normal.
No, not normal. Right. You should be sleeping if you're waking up with something not okay. That's okay. We should put that on a shirt.
Yeah, we should.
Nothing's
Or
normal
mug.
at night.
Nothing's normal at night. You're supposed to be asleep.
All right. So it starts off with a dry cough because at first the inside of your
Shireen
lung...
said no exudate.
No exudate. Yes. Because at the beginning, we're just getting some irritation of the lung because the bacteria is just now starting to kind of break through. All right? What happened?
Debbie just said, diarrhea at night? What's up with that?
Oh, yeah, that shouldn't happen. Don't take a Benadryl and a laxative at night. It's a bad idea.
It's a bad combo.
It's a bad combo. Don't do that. So it starts out dry because there is no exudate. This is just now starting to form. So the lungs feel the irritation and the bacteria is starting to multiply, but we haven't had a bunch of exudate. We haven't had the caseous appearance yet. We haven't had it eating through the lung tissue. Okay? So it's going to start out with a dry cough, and then it goes to a productive cough. Okay? So productive cough means we got a little junk behind it, right? Productive cough means I'm coughing up sputum. All right? Now, usually at first with TB, it's going to be like a clear to a frothy to kind of a grody color, but it's usually just like a normal
to a grody
cough. A grody color. That's like an
You should chart that.
There's a Crayola called grody. Okay?
It is.
And it's this one. So then it's going to go to a productive cough, and then it's going to end up going to hemoptysis. And we talked about that, right? So hemoptysis means that there's blood whenever we cough. And that happens because now the TB is starting to eat through the lung tissue. We're starting to have some bloody sputum that comes up with it. Sometimes in nursing exams, they won't say hemoptysis. They'll say rust-colored sputum, okay? If we have rust-colored sputum, that's not normal. Okay?
Dusty, rusty with TB.
Yeah, it's not good. So rust-colored sputum is not okay. All right, that's something that you're going to be looking for, but that typically happens later on in the disease process versus early, okay? So we've got dry cough that goes to productive cough that goes to hemoptysis. So early, mid, late. They love to test on this. So it's something you need to know, all right? If it says, what would you expect to see with early TB? I would not expect to see hemoptysis. I would expect that late. Aight? All right, so how do our symptoms move? As we go from early symptoms, our cough is starting to change. What are some other symptoms that we're typically going to see that are a little bit later symptoms? Give me some late symptoms of TB. And while you guys are doing that, we're going to start to talk about how we're going to diagnose this. What'd you say?
I was going to say, if we're playing Jeopardy, I'd say, what is death?
What is? Yes, that is the latest sign. Yes.
The consumption.
Yes, we are hoping to fix it before that point. All right.
Oh man, these allergies are still in my American dream.
It's Texas for you.
I know.
All right, anybody know late signs of TB?
That lag though.
Yeah, but I didn't feel like it was that long.
Time flies when you're having fun.
I am having a nice time.
Debbie says frothy is her moist. Apparently doesn't like the frothy.
Oh, she doesn't like the word frothy? Frothy? She doesn't like, Deb, you don't like frothy? You don't like frothy at all?
Come on, Deb.
All right, so we know that we're going to see hemoptysis. That's kind of coming late, right? We may see some very significant weight loss, right? Because these patients can't breathe very well, right? Once we get to that point where this is eating through our lung tissue, you think we're going to have some significant dyspnea, if you will? Why, yes, we will.
Yes,
we will.
Yes, we will.
And then if they have to choose between eating and breathing, then they're going to choose breathing. Most people.
I would choose
you may be a little bit different, but most people will, and so they won't eat because they really feel that crummy. So they get severe anorexia, okay, to the point where we're not eating at all. And then if we're not eating anything, we have to watch out longer term for like electrolyte disturbances and malnutrition and things like that. All right. So these patients are going to have significant weight loss, dyspnea. Now we've got hemoptysis, right? And we will have pretty significant lymphadenopathy, right? Because now it's going everywhere. And what could happen here once we get later with TB is it's either going to eat a hole through the lung tissue and you're going to pop that lung, or you could end up getting this, the bacteria that goes everywhere. We could end up in sepsis or bacteremia, or you could end up dying from actually one of these other comorbidity kind of things that would happen if we're not eating. Our lymph nodes are swollen. This bacteria is taking over our body. We've got bloody sputum.
There's a hole in your lung?
Yeah, there's a hole in your lungs. That's sort of a big deal.
Just filling with nastiness.
Yes, there's a lot of different things that can end up causing death in TB patients. So really it is our goal to catch it early when they start to have these B symptoms or constitutional symptoms. Now, if a patient comes in with a clinical picture that looks like this, okay, then I want you guys to tell me what kind of testing that you're going to order and any kind of special considerations for patients or any questions you're going to want to ask them before we start the testing process, all right? So I want you guys to tell me everything you know about how to test for tuberculosis.
Mary Dillon just joined us. Welcome, Mary.
Oh,
hi, girl.
Mary's our friend, too.
We've got lots of friends.
We have some friends.
You should see our friends list on Facebook. It's extensive. Debbie says chest x-ray.
We will do that. What do we want to do
Amber
right
said that
before
to
we
you.
do that?
Debbie says PPD.
All right, so let's do the PPD. So let's talk about that. Because there's usually lots of test questions on PPDs. So I wrote all these different things because on your nursing exam, you may see them called lots of different things. It can be called the PPD. It can be called the TB skin test. It can be called the Mantoux test. The X is silent. Okay?
I see what they did there.
So PPD, TB skin test, Mantoux test, they're all the same thing. All right? So how we're going to do this is a testing just to see if you've been exposed to the bacteria. Please remember that these are all screenings, okay? So these are not definitive. So if you ever get on an exam, what is definitive for TB, these are not going to be it. These are screenings to tell me what kind of diagnostic imaging I need to continue with or if I need to continue with anything at all. So these are screenings, okay? Have I said that enough? don't pick that as definitive for TB.
Okay, we got, Mark says AFB. Erica says AFB, acid fast bacillus.
Oh, okay.
Smear and sputum culture.
We will end up doing a sputum culture, you're right. But I want you guys to first tell me, what are your considerations for PPD? How do you perform a PPD? Where do you put it? What kind of needle are you going to use? What are you looking to form? What do you have to check for? I want to know everything nursing-wise that you need to know in order to administer a PPD and to interpret the results.
You remember when you gave me my first PPD? It was when I was in college, and you said, "Do you have alligator skin?" Because the needle was like bending real bad, and you're like, "You are weirdo."
You are odd. Nothing has changed.
Nothing has changed.
It's changed.
Many a year ago.
Anybody know anything about PPDs? Tell me what
Yeah,
you
you use intradermal needle, gauge 24.
There we
yes,
go.
you do.
So we're going to do an intradermal needle. All right.
Jenny,
so
Mark, and Kelly. Coming in clutch.
And we're going to put it typically in the forearm, right? Bevel up or bevel down?
Oh man, Erica, she done said all the things.
Oh, she did it?
Yeah, and then Jenny on forearm.
All right, so we're going to go on the
Debbie
forearm.
said it's 15 degrees.
15 degrees. They love to ask
Forms
that
bubble
kind of
under the
stuff.
skin. Patient return in 3 days.
All right, so we know that we're going to use an
Bevel
intradermal needle.
up.
Yes, bevel goes up. Put it on the forearm at a 15 degree. Once we get it, you should still see the needle visible under the skin, or you've gone too deep, because it's intradermal, right underneath the skin. If you go to where you cannot see the needle, you've gone too deep.
Debbie said bevels up, hose down.
Debbie, if you don't come here and visit us here at IUT,
We're going to be very
we're gonna
upset.
be sorely disappointed. We really need to meet your face, okay? So, intradermal needle, bevel up on the forearm, 15 degrees. You want to see the needle through the skin, and then it is our goal to create a wheel. Now, I am going to write this, okay, in a different color, because this gets incredibly tricky on the exams. Our goal when we are placing the PPD is to form a little wheel underneath the skin. That's how you know you did it correctly. So you should see that little raised area, the little bleb, the little wheel, okay? It's not a hive. It's not urticaria. It's not any of that, all right?
I wonder if we have a
Just
TB
form-
needle.
We probably do.
I'll let you give me one.
Okay, we can do that. We'll do it on camera. Gets me some saline too. I'll just put some saline in.
Yeah. So just dissolve.
We're getting real in here today.
BRB.
Yes. So you want to form a little wheel underneath the skin. All right? That is your goal. Now, wheel you want to see while I am doing the test. Do not choose wheel as how to interpret the test. All right? So I want to form a little wheel. I need to see a little bleb there. That means that the TB bacteria that I'm giving is going right up underneath the skin, and I want your body to be able to have some kind of reaction to it. So I want to produce a wheel or a bleb here. I do not want to use a wheel as my diagnostic. So once I produce this, and a couple of you guys have already said that you are going to come back, right, in 48 to 72 hours, okay? And if you come back at 47 hours, all right, you need to tell the patient, go have some lunch, come back in an hour. It has to be within this time frame. If they come back at 72.1 hours, they have to repeat the whole entire thing. It is only valid if they come back and have it read within 48 to 72 hours. That's it. Now, when we're reading it, all right, this is very important, and they love to test on reading, okay? So we are not obviously looking for a wheel. We are looking for an area of induration, okay? We are not looking for redness, okay? So I'm going to put redness. That is a no, okay? We're going to be looking for a wheel. No. All right, so I'm going to draw big X's through these. That is not what we are looking for. And it is very common for them to test you on these things, okay? So we are not looking for areas of redness. It may be red. People are going to irritate it and pick at it, even though you tell them, please don't irritate it or pick at it. They're going to irritate it and pick at it, okay? You can do not cover it with a Band-Aid unless you feel like the person's going to irritate it and pick at it, okay? If you do a Band-Aid, it has to be like so loose. We put the two ends very close to each other so that the Band-Aid forms like a bridge on top of it. It really shouldn't touch that area because that area needs to be able to have some space to react. If you're looking for redness, you're going to read it incorrectly because people will scratch and you'll see big giant areas of redness, but it's not raised at all. Maybe their clothes rubbed on it or something. Do not test for redness, okay? Do not test for a wheal. We're looking for an area of induration or a raised hard area. That's what we are looking for, all right? When you do this, all right, when we look at our area of induration, we need to measure it. And you guys, I want you to tell me what is considered positive for what populations.
We don't have one, but I can get one and we can do another live video later where you give me
Yeah,
one.
we can do that. I would love to give them a needle.
That's how much trust I have in you.
I want you guys to tell me what is considered positive for which population and what positive means.
Kelly says 8 to 10 positive.
In which kind of population would that be considered positive? In healthy individuals with no previous risk factors, okay, and while we're there, tell me what are some risk factors of tuberculosis, and we'll go and write those up at the top. What kind of populations are most at risk for tuberculosis? And I want you to tell me.
Kim said 10 plus 5 plus immunosuppressed.
So we've got 5, 10, and 15 millimeters that it could be, all right? So in our patients that test positive at 5 millimeters, these would be our patients.
Kelly said healthy people for her 8 to 10.
For, according to CDC, and these are CDC recommendations, 5 millimeters positive would be for our HIV patients, so if they're HIV positive, or if they have severe immunocompromised status, all right? So our severe immunocompromised status would be like our organ transplant patients, our patients that have been on corticosteroids for 15 days or more. So chronic corticosteroid use, organ transplants, anybody that is severely immunocompromised, chemo patients, things like that, would be 5 millimeters or more would be considered positive. Our 10 millimeter patients are the ones that are more at high risk, all right? So these would be patients that work in a TB, patients that work in a TB lab, patients that come from an area or have recently traveled to an area that has a lot of tuberculosis, so there'll be recent travel. If they have any contacts that were very close to them that have had TB in the past or very recently, they would test positive at 10, okay? Normal healthy individuals with no previous risk factors are going to test positive at 15. So these are our healthy individuals here. No risk factors, just normal healthy people, okay? These are CDC requirements, so we test positive at 5, 10, or 15. Now,
Erica said positive TB skin test means a patient has been exposed to TB at some point. It does not mean they have active TB
absolutely,
infection.
and that is often a test question you're going to see, okay? So I want you guys to very clearly understand that, all right? I'm going to move this so I can have a little bit more room. So if they do test positive, so say you have an HIV positive patient, they're at 7 millimeters, they have tested positive, do we go in and say, sir, you have tuberculosis?
I regret to inform you.
We do not, okay? We don't say that because remember, this is a screening, okay? So this means that at some point, this patient has been exposed to tuberculosis. Now, I've had students that have come in here, Ivy League students that come in here all the time. They got their TB skin test before they started nursing school, and then they go, and for their next year's TB skin test, and it's positive. You're in the hospitals, you're in the clinics, you're getting exposed to it all the time. It doesn't mean you have it. So make sure when you tell patients your TB skin test is positive that you don't just leave it there, okay? Because one of two things is going to happen. When you say your TB skin test is positive, they're going to be like, oh my gosh, I got a positive result.
Yes!
I feel good. I'm
nailed
positive.
it!
Yes. People don't know what positive and negative means. And if you notice as you go through nursing school, positive and negative actually does mean different things for different tests. So don't just leave it there. Make sure that you explain to them what that means, all right? So in these patients, if they test positive, then that just means that they have had a recent exposure at any time. That means that they could have miliary in their organs, they could have pulmonary that's sitting in their lungs, they could have latent that's just lying there, okay, that doesn't really need to be treated. So this positive just means you've been exposed, okay? So this here means exposure. Now, what kind of patients would test positive no matter what? And we no longer will do PPD skin testing for those patients.
Somebody up here said what I think what you're looking for.
Did they?
Let me find who it was. Because they said if you had TB or had the vaccine.
Yes. What's the vaccine called for TB? We don't have it here. but they do have it in other countries because their prevalence is so big. Anybody know?
I'm trying to find what.
If you have had the BCG vaccine, okay?
Debbie just came in with it.
She's always like right with me.
I just feel like she gets us.
She does. So if you've had the BCG vaccine, which is the vaccine for TB, then you're going to skip this. You're going to skip this testing portion all right here.
Yes.
Because if you've had the vaccine, then of course your body's going to have developed antibodies against tuberculosis because it was a vaccine. And that's what vaccine's job is to do. So if they've ever had the BCG vaccine and you need to ask before you do a PPD, you're going to skip this whole thing and go to our next step. Actually, I'm going to make it go this way. What is our next step? After they test positive on this PPD or TB skin test or MAN2 test, what's the next thing we're going to do?
Camille says x-ray.
All right. Now I'm going to do a chest x-ray.
That's what I have to do every time. I can't do the PPD. Ew, I'm nasty.
Because once you've had the chest x-ray, all right, then what would I expect to see on a chest x-ray?
If they had it, or what would you expect to see if they don't have it?
Either way, what would you expect to see on a chest x-ray?
Lungs.
If this is positive, I've just been exposed, then my chest x-ray is going to be negative, and we would just stop there, right? So if my chest x-ray is negative and I don't see anything, it's a perfectly clear chest x-ray, then that's it. I'm done. Okay? So we don't need to do anything else. We are done. Okay?
Yes.
Now, if I do a chest x-ray and I see this,
Ew.
you guys, you really need to, if you haven't Googled it yet, go and look at a TB x-ray because it is fascinating what it looks like. If the chest x-ray is positive and you see anything on the chest x-ray that looks a little suspicious, your chest x-ray is positive for, I don't know what, right? Looking at an x-ray only shows me, hey, there's something there that I really need to look at a little bit further. But we know from the beginning that this was a bacterial disease caused by Mycobacterium tuberculose. So what would I do if my chest x-ray is positive? What's my definitive? Because again, this is a screening. This is not definitive.
Mark said consolidated lungs.
We will
Smiley
see that in
face.
the chest x-ray. And then what happens, what do we do after that to see if this is actually TB?
Oh. Debbie says Debbie is an x-ray tech becoming a nurse. Woot woot.
Oh, really?
I like how she referred to herself in the third person.
It's Debbie. Debbie says we're going to do a sputum culture. Debbie's right. Okay? So our last thing is to do
Erica
a sputum
said
culture.
gold standard for confirmation of TB disease is AFB smear and sputum culture.
Yes. So the AFB is when we're talking about the acid-fast bacilli. We will usually see that happening on the smear before we will get the sputum culture back. The sputum culture can come back weeks later, right? So in the sputum culture, we will see that be positive for Mycobacterium tuberculose, and that, my friends, is finally our definitive. We will be positive for Mycobacterium tuberculose. This is our definitive. So if they ask you on an exam, how do we definitively? Now give me your nursing considerations for collecting a sputum culture. What do you need to do?
Got time to dig deep.
Yes, dig deep. Because I saw sputum culture all through nursing school. That is the worst noise on the planet. If you do it again, I will never talk to you for as long as I live. The sputum culture I just think was spit. It's not spit, okay?
You gotta dig deep.
You do. You have to go deep. So usually have your patients sit up on the side of the bed in order to get good lung expansion. You're going to have them take a couple of really deep breaths. You do not want to do this around mealtime, otherwise you're going to get carrots and gravy and whatever else they ate inside the sputum culture. So make sure that they have not recently eaten. They usually should do something to rinse their mouth out a little bit before, not mouthwash. You don't want to do that. Just have them rinse with a little bit of water is fine, just to kind of rinse out their mouth a little bit. Have them sit up. Make sure that they've been pushing fluids the couple days before or the day before. If we can increase their fluids, then that will help to thin out the sputum enough, or the junk enough, that they are able to cough it up. So have them sit up, take a couple of deep breaths, and then you want to tell them to try to make a productive cough. So they're going to take those deep breaths to open up the lungs, and hopefully that'll kind of trigger
Serene said, don't stand in front of them. No,
Definitely
you
don't stand in front of them, or you're going to get TB in the eye. Or
Oh,
be very cautious.
no.
Now, TB is airborne, which we're going to talk about in a second, but if you are collecting a sputum culture, I would recommend wearing something on your face.
You wear that shield.
Wear something, because that sputum can get on you, it can get in your face, it can get in your eyes, and get in your mouth, and
Gross.
You don't want to go there.
You don't want that.
You don't want that. So do make sure that you're using your PPE very effectively when you're doing the sputum culture. So increase fluids, have them sit up, take a couple deep breaths, and try to get that productive sputum to cough, and then to spit whatever they coughed up into a sterile collection container, and we send that off. All right? That is definitive. Now, what does my treatment look like for TB? And then as soon as I think that this patient has TB, we're going to go ahead and initiate precautions, okay? And so when we initiate precautions, I want you to tell me what that looks like.
And I said antibiotics.
Yes, we are going to use a regimen of 4, and the acronym for that is RIPE. So
Erica just said that.
Tell me, very nice. Tell me what the drugs are that are included in RIPE. All right, so I've written them up here. I'm sure you guys are coming in with in the clutch, but we've got rifampin, isoniazid, right? I don't know what I spelled. Isoniazid, pyrazinamide, and ethambutol. All right. A couple of really big things that they like
They're
to
coming
ask
in
very quickly.
They're getting on them.
Rifampin turns everything red.
Yeah,
okay,
it is.
Tears, blood, sweat, urine, blood. It turns blood red. Be careful.
Blood? No.
Sweat, tears, it turns everything red, so you need to know.
It'll dye your contacts red.
Yes, it can dye your contacts red, so don't wear contacts while you're on rifampin. It's not something I would notify the healthcare provider for. That is an expected side effect, but you do need to tell your patients that. Ethambutol EEE for eyes. If you see any adverse effects that are eyes, it's going to be your E ethambutol. Okay, so those are typically the ones that you're going to see tested on. Okay. All right, so we're going to do a regimen of RIPE, and that usually is from anywhere from 6 to 9 months. Okay, that is a long period of time. We have to make sure that our patients are compliant. All right, there are nurses out there that their job is to track down TB clients and to make sure that they are compliant. That is called direct observed therapy. They will go out, they will find you, and they will watch you, directly observe you, take your therapy. All right, because you are considered a public health hazard. It is a very contagious disease. It can be spread very, very easily. And so we do not want patients to not take their medications. There are nurses, you can get a job doing this, where your job is just to go hunt down TB patients and make sure that they are compliant on their medications. All right, so that's something we really, really need to check up on. All right, so we have walked this patient all through this process. Now tell me, while they're in the hospital, very quickly, what kind of precautions do we need to be on, and what are the nursing considerations for those?
Oh, everybody already came in with the airborne.
Oh, they did already. All right, so
they're on it. They said N95.
Who has to wear the N95?
The nurse.
The nurse does, right? Because that's a specially fit mask just for the nurse. The patient doesn't really have to wear anything while inside the room. If the patient's going outside the room, then we just wear a simple face mask is enough for them, okay? So we're going to be doing airborne precautions. And considered in airborne precautions, they typically need to have a private room. The nurse is going to wear the N95. All right, so we put an in for nurse here.
Gown and
the
gloves.
Patient wears nothing unless they're going outside the room. Then we do the simple face mask. We need a negative pressure room, right?
Mm-hmm.
And we need to notify all of the household contacts in order to get them tested. And oftentimes we go ahead and just treat the family, even if they're not producing any symptoms or we're still kind of walking through this process. All right? So we've done a lot of things. Once the sputum cultures come back negative, then we consider the patient no longer contagious. The patient, of course, can't stay in the hospital for 9 months, so we're going to send them out after we get them on a good regimen and notify them of all the side effects. Now, just so you know, most of the TB drugs can be liver toxic, so always watch PATIC. I put it on this side.
Yeah,
always watch PATIC and make sure that you're drawing their ALT, AST, and alkaline phosphatase. All right, those are our liver enzymes. Also watch for their bilirubin levels and look for jaundice. So make sure that we have a good, healthy liver. We're avoiding alcohol while we're on these medications as well. Okay?
Ooh, that's rough.
That's a lot.
You had the
For
TB.
9 months.
You got 9 months. It's like being pregnant,
It
except
is.
for much worse.
Except for worse. It is. It's rough. And so these patients do need a lot of emotional support. And it is difficult to treat the whole entire family. I mean, that's a lot of therapy to go through. So this is kind of the whole
said
process.
CDC
So let's
must
go
be
through
notified.
very, very quickly and replay what we
Yes,
did.
girl.
So we know that tuberculosis is a bacterial disease. It is a bacteria that is called Mycobacterium tuberculi. Risk factors would be being in a country that has much more tuberculosis, which we don't have here, but in other developing countries, it is very, very high. Low socioeconomic status or crowded living conditions can be a risk factor. Homelessness, IV drug users, those kind of things can put you more at increased risk. Once we get exposed to the bacteria through airborne, it is either going to go into our pulmonary, cause pulmonary TB, which could be an active infection. If it was our first time, that's our primary infection. It can go into our organs and cause miliary TB, or it can go somewhere in our body and just be latent and lying in wait. It is going to come into the lungs and form a gone focus that starts to eat through our lung tissue and wall itself off, causing a caseous appearance or a cheesy appearance. Early on in the disease process, we're going to see our B symptoms or constitutional symptoms, which are weight loss, fatigue, night sweats, fever, and malaise. That is going to progress from dry cough to productive cough to eventually hemoptysis, which is later. If you see rust-colored sputum, not okay, we don't like that. If you see frank blood whenever you're coughing, we don't like that either. They're eventually going to have significant weight loss, dyspnea, lymphadenopathy, severe fever, severe anorexia, hemoptysis, okay? When we start to get signs and symptoms of TB, we're going to get a PPD, also called a TB skin test, also called a Immune 2 test. These are only screenings. These are not definitive or diagnostic. We're going to use an intradermal needle. We're going to insert it at 15 degrees into the forearm. You want to see the needle underneath, bevel up, okay? You're going to form a wheal or a little bleb underneath the skin. You're going to have them come back in 48 to 72 hours. We are not looking for redness. We are not looking for a wheal. We're looking for an area of induration, which is a hardened, raised area, okay? If they are 5 millimeters, it is considered positive in HIV in severely immunocompromised individuals. 10 millimeters would be patients that work in a TB lab, had recent travel to a TB country, has recent TB contacts, people that we know have had it. 15 millimeters in healthy individuals who have no previous risk factors, it's considered positive. If we're positive, then we go and we do a chest x-ray. If it is negative, we are done and we repeat the test again next year. You have a chest x-ray. If it is positive, we're going to go get a sputum culture. That sputum culture would be positive for Mycobacterium tuberculosis. Then we're going to go into treatment, into our right therapy. Watch your liver. Make sure that you're compliant on your medications. Get them on Airborne Precautions. You need to put on that N95 mask. Get your patient in a negative pressure room, preferably private room. If the patient's going outside or they're going home, they need to be wearing a face mask at all times, okay? And then we treat them and we fix them, and then we are Florence Nightingale.
Florence Nightingale.
We have done it, okay? Make sure that you are treating any household contacts and you have them talk to people who they've had recent contact with so they can be tested as well, all right? That's the quick and gritty, dirty version of tuberculosis, okay? If you guys have any questions, go ahead and pop on in real quick. I'm going to stay on for just a minute or so longer. Just make sure you don't have any questions.
It's going to cut us off soon, though, so we got to make it quick.
Okay. All right.
Carolyn said, what specific assessments do we do, i.e. temp lung sounds?
Lung sounds, yes, we are going to listen to. We're going to check temperature. We are going to monitor for adverse effects of any of these, which would be like blurred vision, any eye problems. Watch their eyes, nose. Look for jaundice. Check bilirubin levels, ALT, AST, alkaline phosphatase. We're going to be have them on an SpO2. They may be on oxygen. Typically, they won't need to. Watching our medications, do medication therapy. Therapeutically, we need to send them to a social worker to make sure that they can get their medications and then they can stay compliant. We'll find a way to get those covered through insurance. If they don't have insurance, we'll have to find a way to do that too. Sit the patient upright, especially if they're dyspneic. Okay? Watch that SpO2 closely and make sure that we're giving them any kind of respiratory support that we need. All right. It's
cutting us off in like less than 2 minutes.
All right.
So if y'all have any other questions, just comment them and we'll go comment the answers to y'all.
Absolutely. And we'll be sending some follow-up questions on this feed, so be looking through the feed and look at some follow-up questions that we're going to be sending you. And then we will have some other free seminars starting next month. And then don't forget to check out our Facebook Live, Learn All the Things seminars, because we're going to be starting those up in 2 weeks. Oh, a little less than 2 weeks. A week and a half. So you guys get on it and get ready for next semester. I hope y'all are enjoying your break. Thanks for joining us during your break. That was really awesome.
MVPs.
Yes, and we will see you guys soon. All right. Take care.
Bye, y'all.